Okay, good morning to Dr. Fairuz and Dr. Hafiza. Today I will be presenting about sepsis and septicaemic shock. So first, according to the meaning, infection is an invasion and multiplication of microorganisms such as bacteria, viruses, and parasites. This will cause a reaction by the host tissue to the infectious agent and the toxins they produce lah. So they may have no symptom and be subclinical, or it may cause symptoms and be clinically apparent. So infection, bacteremia is the presence of bacteria in the blood. It can be classified in two types: community-acquired infection and hospital-acquired infection, or nosocomial infection. So community-acquired infection is an infection that are contracted outside of the hospital or are diagnosed within 48 hours of admission without any previous healthcare encounter. Hospital-acquired infection is an infection that is acquired in the hospital or other healthcare facility. So an infection it will cause a host response lah. So the immune system will recognize and destroy the substance that contain antigen on the surface of the virus or bacteria. This will then cause an inflammatory response lah. The injured cell will release chemical including histamine, bradykinin, and prostaglandin lah. The immune system also includes certain types of white blood cell, and it may include chemicals and proteins in the blood such as antibodies, complement proteins, and interferon. So the host immune response will further causes several symptoms and signs in the patient lah. Some of the symptoms will depend on the site of infection. For example, fever, cough, headache, abdominal pain, vomiting, dysuria, and vaginal discharge or rashes. Some of the signs also include tachycardia, tachypnea, diaphoresis, hypertension, acute abdomen, confusion, lethargy, and oliguria lah. So for the SIRS, it is an systematic inflammatory response syndrome, which include tachycardia, which is heartbeat more than 90, tachypnea, when the respiratory rate is more than 20 breaths per minute, fever or hypothermia, and total white blood cell less than 4,000 or more than 12,000 lah. So sepsis, it has several definitions. According to the 1991, sepsis is defined as infection or suspected infection leading to onset of SIRS lah. And then in 2001, it was then redefined to the presence of at least 2 SIRS criteria and a confirmed or suspected infection lah. So severe sepsis is sepsis with organ dysfunction, and septic shock is defined as sepsis which include hypotension persisting despite fluid resuscitation lah. And then in 2016, they introduced another meaning for sepsis lah, according to the Third International Sepsis Consensus Definition Task Force. So sepsis is a life-threatening organ dysfunction due to a dysregulated host response to infection. For clinical operationalization, organ dysfunction can be represented by an increase in the sequential sepsis-related organ failure lah, or assessment according to the SOFA score 2 points or more, which is associated with an in-hospital mortality greater than 10% lah. So this is the QSOFA. It means quick sepsis-related organ failure assessment lah. It is usually used in ED to identify infected patients who are likely to be septic outside of, for ICU admission lah.
So gunakan ID? So semua patient awak kira lah quick sofa? So awak kata commonly, usually. Kalau saya tengok documentation, berjumpa lah korang tulis quick sofa.
Usually patient yang dalam infection punya patient
so korang kira
lah.
lah SOFA score ni for patient yang ada infection.
Sepatutnya kira lah.
Okay.
This is the QSOFA, which is used to recognize sepsis lah. It is when the respiratory is more than 22, the systolic blood pressure is less than 100 and patient have altered GCS lah. We can suspect sepsis or organ dysfunction when there is increase of 2 or more in the QSOFA lah. This is the SOFA scoring system to predict mortality lah. This is usually used in ICU atau ICU setting. They will usually calculate according to the system function lah, which is respiration, coagulation, liver, cardiovascular, CNS, renal and renal lah. Usually when patient is admitted, they will calculate the baseline first and then calculate dia akan calculate daily untuk nak tengok whether the organ dysfunction worsening ataupun tak.
Okay, so clear semua orang clear bila masa nak kira SOFA score ni yang ICU pakai ni, dia digunakan dalam ICU lah. Satu, untuk determine whether patient punya organ dysfunction or organ failure ni worsening or static. Sebab sometimes dia SOFA score ni yang full lah, SOFA score full, bukan quick SOFA. SOFA score yang full ni is a measurement, is a tool untuk determine korang patient punya state of organ failure. Maksudnya patient masuk ICU akan kira lah baseline SOFA score. Then day to day diorang akan kira SOFA score. If SOFA score increase by 2 or more, maksudnya patient punya organ failure is worsening and the mortality rate will increase lah. So kenapa kena pakai SOFA score ni? Sebab some patient ada chronic illness. So baseline dia memang dah ada some sort of kidney failure or liver failure or apa-apa failure lah. Okay, so SOFA score ni it's not something that you do in ED. Sebab come on lah, korang GCS pun masih gagap, apatah lagi nak hafal SOFA score ni kan. Dah lah ada 0, 1, 2, 3, 4 komponen pula, ada 1, 2, 3, 4, 5, 6, 7 kan. So maximum score dia 28. So GCS yang maximum score 15 pun semua masih gagap lagi, sedangkan SOFA score. Tapi untuk ED, that's why dia develop quick SOFA. Apa tujuan quick SOFA ni?
Rapid assessment.
Assessment of what?
Severity of patient.
Severity of patient apa?
Infective patient.
Okay, so first patient tu, kalau patient tu ada infection, memang patutnya korang dah quick SOFA ni is done for patient yang ada infection. Dia tak query dah patient tu. Infection lah. You know, whatever patient tu ada infection lah. Quick SOFA ni, infection tu awak kena identify dulu. Patient ni dah ada infection. Okay. So, out of say 10 patient yang ada infection, 10 ni awak kira lah quick SOFA. You know, H18 lah. Heart rate, altered sensorium dan BP kan, tachypnea kan. Dia mnemonic dia adalah HEAT. H for heart rate, H for hypotension, A altered sensorium and T for tachypnea. Faham? So itu dia quick SOFA tu is a simplified form of SOFA score. Tujuan dia is for screening. Dia awak nak screen patient infection. So kalau patient tu ada score quick SOFA score 2 out of 3 or more kan, dia score 2 or more, so nak buat apa?
ICU.
Yes. Inilah tujuan dia. So kalau awak ada 10 patient yang ada infection, 2 tu score SOFA, quick SOFA score dia 2 or more kan, 2 orang daripada 10 ni, 2 orang quick SOFA score dia 3. Yang lain tu quick SOFA score mungkin 1, mungkin 0, apa semua. So yang 2 ni kena masuk ICU. Dia kena manage dekat ICU. Inilah tujuan quick SOFA ni. Bukan nak tahu patient tu ada infection ke tak ada infection. And awak tak buat quick SOFA ni kepada semua patient yang main kat ED, because patient trauma pun kalau buat quick SOFA 3 pun. Tapi dia trauma. So quick so far ni jangan buat kat patient trauma. Dia patient yang ada infection sahaja. So dan
Ya.
patient yang score 2 or more, patient ni lah priority untuk masuk ICU. Tapi kenapa benda ni tak berapa applicable kat Malaysia?
ICU limited.
ICU selalu full.
Oh, full.
Limited lah, limited ICU beds. ICU selalu full. Kan? Kalau even awak tengok kat HSAH kan, patient intubated pun boleh tentu boleh masuk ICU. Apatah lagi patient sepsis yang quick so far 2 out of 3 single inotrope. Rasa masuk ICU? Akan diberi priority untuk masuk ICU? Takkan. So this is benda yang kita akan masuk later lah. Kita boleh discuss pasal how valid is this recommendation kat negara macam Malaysia. Macam mana kita nak sesuaikan dengan setting kita lah. Okay, carry on.
Okay, Doctor. So, septic shock, according to the 2016 definition, is a subset of sepsis in which particularly profound circulatory, cellular and metabolic abnormalities are associated with a greater risk of mortality than with sepsis alone. It is usually clinically identified by a vasopressor requirement to maintain a MAP of 65 or greater and serum lactate more than 2 millimole per liter lah, in the absence of hypovolemia. Usually the hospital mortality rate is more than 40%. So this is the operationalization of clinical criteria to identify patient with sepsis and septicemic shock lah. So macam Dr. Faris cakap tadi, if a patient is we suspect ada infection, we need to use the Q-SOFA lah. And then we assess the evidence of organ dysfunction according to the SOFA yang table ICU guna tadi tu. And if patient have sepsis, despite adequate fluid resuscitation, kita tengok if dia perlukan tak vasopressor nak maintain the MAP more than 65 or is the serum lactate more than 2. If dua kriteria ni ada, meaning patient ada septic shock lah. So this is the 1 hour bundle to manage patient in septic shock lah. We need to measure the blood lactate level, remeasure it if it is more than 2 micromole per liter. And then we need to take blood culture and administer broad spectrum antibiotics against suspected organism lah. And also start IV fluid resuscitation and administer vasopressor to raise the blood pressure lah. So this is the initial resuscitation for sepsis and septic shock lah. Yang macam saya cakap tadi, measure the lactate level, take the blood culture, give appropriate antibiotic, and then administer IV fluid and give vasopressor lah if BP is hypertensive or MAP less than 65. So we can also establish venous access such as CVL for CVP monitoring and take appropriate blood investigation lah such as FBC, LFT, coag or D-dimer. And if we take ABG, it may also we take it to see if patient has acidosis, hypoxemia or hypercapnia lah. Measure the serum lactate. Usually if the serum lactate is more than 2 or greater than the upper limit, it may indicate the severity of sepsis lah, and used to follow the therapeutic response. And then take peripheral blood culture prior to administration of antibiotic. And take urine, CNS or other microbiologic culture lah from suspected source such as sputum, CNS, urine, CNS or any wound from the surgical site or body fluid lah. Then we can also do imaging to target the suspected site of infection lah, such as chest X-ray, CT of chest and or abdomen lah. So the initial resuscitative therapy is we need to...
Izzah pergi slide sebelum ni. Sebelum ni?
Sebelum.
Okay. So, okay. Pergi slide depan.
Depan.
So mana datang establish venous CVL, CVP monitoring, SCVO2 reading ni?
Kalau hypotension tu.
Venous access tu saya tak ada masalah lah, establish venous access. Tapi CVL, CVP monitoring, SCVO2 reading ni ada dalam recommendation yang 2016 ke? Ke ni dah campur recommendation yang guideline sebelum ni?
Dia gabungan guideline.
Tak boleh gabung. So SCVO2 reading ni yang benda? Dah awak tulis kan, saya tanyalah.
Systemic venous oxygen reading.
So macam mana nak measure?
Through CVL punya line. Kalau tak silap saya lah, dia ambil VBG through the CVL.
Okay.
And then
So apa significance dia?
I'm tak sure.
Apa yang awak nak tengok?
Lactate.
Okay,
tak
so,
sure tak saya.
okay, tak apa. So sebab tu saya tanya, sebab bila tulis ni kena tahulah. Okay, ini yang CVL, CVP monitoring, SCVO2 reading ni adalah recommendation from guideline sebelum 2016. Ni sebahagian daripada EGDT, Early Goal Directed Therapy. Sebelum sepsis, masa zaman-zaman SIRS apa semua ni, sepsis ni dia mempelopori benda yang popularly known as EGDT lah, Early Goal Directed Therapy. Sebelum ada recommendation yang 2016, Early Goal Directed Therapy ni, one of the recommendation adalah semua patient sepsis kena buh central line. And one of the ways you monitor patient progress is by doing SCVO2 reading ni lah. SCVO2 reading ni basically is VBG lah. Tapi VBG from central line. And what you look at is the SpO2 punya level or dia punya saturation level. So dia if the SpO2 level fall below certain range, it indicates ada increase in peripheral utilization of oxygen. Maksudnya patient tu is in shock. And they thought that this is a good way to monitor patient progress lah. Maksudnya kalau SvCO2 increase, reduce peripheral oxygen consumption, shock is improving. However, after more research and study, EGDT has been proven to be not any more beneficial than konservatif punya way lah. So and dia tambah complication of, because semua patient now bubuh central line kan, bubuh internal jugular, patient have more complication of central line incision, infection, pneumothoraxes, failure dan sebagainya lah, hematoma dan sebagainya. So EGDT sudah tidak direkomend lah. So kalau baca the latest guideline, tak ada dah suruh semua sepsis patient both central line. Even kalau baca yang 2016 and above, even kalau patient on inotrope pun boleh bagi through peripheral line. Kalau kata tak ada central line, bukanlah wajib bagi through central line. I mean, if at least in the initial part lah, so you can start patient on inotrope pakai peripheral line. So we are moving away from semua patient sepsis bubuh central line, because unless kalau setakat untuk monitoring, it's not more beneficial. It probably gonna cause more complication. Unless you ada reason lain nak pasang CVL, e.g. for example nak patient on triple inotrope ke, or patient difficult IV access ke dan sebagainya, yes, you insert. Tapi not all patient kena bubuh central line. Sebab bila awak bubuh dalam ni, seolah-olah semua sepsis patient kena insert central line and kena buat SCVO2 reading. Sedangkan benda tu sudah di-prove tak ada beneficial and it's not an accurate measurement of septic shock, improving ke, worsening ke. So kalau buat juga seolah-olah buat benda yang membazir lah. Dah lah central line, VBG pula tu, pakai central line, membazir lah RM5 setiap kali buat VBG tu, and it doesn't help you in any way. So pada saya yang lain ni okey lah, stabilizer respiration ni A kan, yang lain, tapi establish venous access, CVL, CVP ni it's not recommended for all patient. Bukan kata salah buat, tapi kena pilih patient, not general recommendation. Okay, takut nanti awak buang masa, patient sepsis sibuk duk buang masa nak insert central line rather than doing something yang truly beneficial for the patient. Okay, so kena tahu tu. Okay, carry on.
Okay, this is the initial resuscitation therapy. First, we need to rapidly restore patient's perfusion and give early administration of antibiotic lah. So the tissue perfusion is predominantly achieved by the aggressive administration of IV fluid, usually crystalloid lah, and started by 1 hour and completed within the first 3 hours following the presentation. And then empiric antibiotic therapy is targeted at suspected organism and site of infection and preferably administered within the first hour. And then early goal-directed therapy is, okay yang ni tak. Ni tak. Semua yang bawah ni tak kan?
Apa dia?
Yang early goal-directed therapy ni kiranya
dah sudah tidak ada dalam recommendation lah. This is I mean yang SVCO2 ni tak ada dah. CVP, SVC2 dengan CVP tu dah tak ada dalam recommendation. Tapi MAP more than 65, urine output more than 0.5 mils per kg per hour ni masih value yang kita pakai lah. Tapi yang SVCO2 dengan CVP measurement yang invasive ni, it's not for everyone. Kalau patient dah duduk dalam ICU, itu cerita lain. Tapi maksudnya, it's not for every sepsis patient. Kalau dah awak duduk kerja insert central line je lah. Kat ED ni. Okay. So goals ni dah ni. So this is guideline from before. Sekarang ni semua orang pakai guideline. Kalau kira ada guideline 2021, I'm sure tak baca pun kot. Tapi dia yang banyak orang duk pakai sekarang is guideline 2016-2017 lah. Surviving Sepsis guideline. Google je ada Surviving Sepsis campaign punya guideline. So ada 2021 punya guideline, dia beza sikit je dengan yang 2017 punya, lebih kurang lah, generally tak adalah new penemuan terbaru ke apa semua, dia ada sikit-sikit, dia fine tune je lah yang 2017 punya. Tapi yang early goal directed therapy ni was something trending lah, sekitar 2008, 2010 macam tu lah. Tapi people are moving away lah from early goal directed therapy. Kalau baca early goal directed therapy ni macam bagus, tapi unfortunately research has shown it doesn't offer any more benefit than conventional punya method. Okay.
So this is the element of care in sepsis and septic shock lah. Recommendation adapted from the international consensus guideline. So any sepsis and septic shock emergency and they should be treated right away lah. Okay. And then resuscitation should begin with IV crystalloid within the first 3 hours. And then if patient has elevated serum lactate level, the resusc should be guided towards analyzing these levels as possible lah. And we should maintain patient BP more than 65. Norepinephrine is recommended as the first choice of vasopressor lah.
Yang ayat atas tu kenapa skip?
Sebab saya tak sure tu.
Skip mana boleh macam tu. Hydroxyl starches and gelatins ni yang benda? Gelafandin. Kena saman dengan gelafandin nanti. Awak telah memburukkan nama gelafandin.
Tak sure.
Gelafandin ni apa benda? Gelafusel, gelafandin. Gela ni, what is it? What is it? Crystalloid, colloid?
Dia colloid.
Colloid. Okay, so colloid ni apa benda? How does it work? Ni soalan basic je. Soalan medical student. How does colloid works? How does colloid works compared to crystalloid? Macam mana kira kat patient BP low kan? Lepas tu kita kata, dah bagi normal saline, BP dia up and down. So bagi jela lah. Apa tujuan awak bagi jela tu?
Dia nak preserve osmotic.
Kawan-kawan lain boleh jawab. Jangan bagi Izzah sekarang je. Izzah pun boleh suruh kawan-kawan lain jawab. Tapi Izzah nak jawab, Izzah jawab lah. Tak masalah.
Dia for maintain osmotic pressure.
How?
Increase volume. Saya tak sure tu.
Okay. So, Jelafandin ni, dia basically macam how does your albumin works? Albumin, human albumin, apa dia buat?
Albumin.
Ha. Albumin, how does it? Dia bukan osmotic pressure. Albumin ni dia exert oncotic pressure. Dia large molecules. So dia exert oncotic pressure. Dia pull fluid from extracellular from extravascular into vascular lah, and dia doesn't leak out as easily sebab dia large molecules kan. So dia exert oncotic pressure lah. That's how dia causes bukanlah hypertension, it maintains the blood pressure lah because it stays in the vascular compartment longer. Macam normal saline ni it doesn't, dia crystalloid, dia doesn't stay in the vascular compartment. Awak bagi after a while dia akan disperse balik kan. So with macam albumin ni dia stays in the vascular compartment, dia large molecule, dia exert oncotic pressure, dia serap masuk and it stays longer in the vascular compartment lah. So Jela ni because albumin is very expensive and it's, sebab dia human based kan. So human albumin yang awak bagi dekat patient liver failure yang low albumin kan. So it's expensive lah nak mass produce untuk bagi untuk semua patient trauma. So Jela ni is a form of synthetic punya albumin lah. Okay. So hydroxyl starches ni function dia tu lebih kurang macam ni, dia exert oncotic pressure, dia large molecule, tapi dia instead of pakai macam synthetic albumin, dia adalah kanji. Contoh dia, this is something yang masa sekitar 2008 baru keluar and it was the hot stuff lah. Benda yang semua orang kata, oh this is the magic apa fluid lah, and supposedly more superior than Jela sebab dia fully synthetic. So Jela, kalau awak tahu, Jela ni people always talk about the potential to cause anaphylaxis sebab dia ada some immune punya komponen, dia ada some dia bukan fully synthetic lah, so ada potential untuk cause allergies and anaphylaxis. So people always a bit cautious about using Jela. So bila hydroxyl starches ni, contoh dia Voluven. Pernah dengar Voluven? Pernah dengar? Sebab sudah diharamkan dari hospital KKM sekarang. Voluven ni come up in 2008, 2007, 2008. Dia start popular kat Malaysia lah. Was sold as a miracle fluid lah. Sebab supposedly dia tiada anaphylaxis or allergic punya potential sebab dia fully synthetic. So masa tu it was used everywhere lah. It's very expensive, used everywhere, especially dalam ICU or gynae lah. Gynae suka lah benda ni kan, patient ONG beranak, bleeding or Caesar bleeding, Voluven lah is the choice. So semua orang tak nak guna Jela sebab takut patient develop allergic reaction. So after about 10 years of 5, 6, 7 years guna Voluven ni, hydroxyl starches, research has shown that Voluven ni causes increased mortality in patient sepsis. Patient sepsis, awak bagi Voluven, awak bagi hydroxyethyl starches ni cause increased mortality. Saya tak ingat kenapa reason dia, tapi cause increase mortality, very significant increase in mortality. So lepas pada tu Voluven is banned lah from usage for patient yang ada sepsis sebab dia independently is cause for increased mortality. So after dah ban daripada patient sepsis, eventually orang kata, you know what, might as well ban je lah semua terus sebab tak payah beli terus lah dekat hospital kerajaan ni sebab nanti kan ada orang terguna untuk sepsis. So we are back to Gelafusil, Gelafandin apa semua. Itu sejarah dia lah. So volumen lah. Mungkin generasi korang tak pernah jumpa volumen sebab dah tak ada dah kat hospital kerajaan. Sebab dah tak beli dah. Sebab because of that lah. Itu cerita panjang dia lah. Bacalah hydroxyethyl starches. Dia now it falls out of favor lah. Tidak anymore. So awak ada jela je lah dengan kristal. Okay.
Okay.
Carry on.
Then dopamine use is suggested when patients show persistent evidence of hypoperfusion despite adequate fluid resusc and use of vasopressor. And red blood cell transfusion is recommended only when the HB decreases to less than 7 in the absence of acute MI, severe hypoxemia or acute hemorrhage lah. Okay, doktor.
Okay, so just go back to slide yang ada gambar tadi.
Gambar.
Yang gambar orang ni. Okay, for ED at our level, the most important thing is for you kena recognize whether patient tu ada infection ke tak lah. First, patient datang, dah assess, you need to be able to recognize whether patient tu ada infection or not. Either history, bedside investigation dan sebagainya. Once dah identify whether the patient is having infection, then patutnya kira lah quick SOFA tu. It's for you to determine which patient yang should be prioritized untuk masuk ICU. Okay, so then these are things that you should do dekat ED lah. 1, 2, 3, 4, 5. Benda yang penting adalah, blood culture, antibiotics, fluid resuscitation. And if MAP persistently less than 65, to start vasopressor, which is no adrenaline. This is kita punya core kerja lah. This is something that you should be able to do. Bukan benda complicated sangat pun. These 1, 2, 3, 4, 5 things that benda yang patutnya jadi, your breakfast, lunch and dinner lah bila you kat ED ni. Okay, identify, because most of our patient, boleh kata 80 to 90% yang masuk red zone or yellow zone or whatever, ada some sort of infection. And bila banyak macam tu, one of the ways for you to screen which patient yang really ill is do the quick SOFA score. And so that you can prioritize this patient for admission to ICU. Okay, macam saya cakap tadi, ICU is always an issue kan dekat Malaysia because there's limited beds, katil selalu penuh apa semua. The Surviving Sepsis Campaign punya guideline ni is developed based on facility dekat negara maju. So for them, ICU tu is not big of an issue lah compare dengan kita. I mean, you're not gonna see intubated patient or patient on anitropes dekat general ward macam kita. So that's why for them, okay, quick SOFA je, masuk ICU. This patient should be managed in ICU. That's why kalau awak baca the recommendation tu, dia banyak fokus kat ICU punya recommendation kan. Pretty much yang luar ICU ni 1, 2, 3, 4, 5, 6 je. The rest is ventilator setting, nak bagi feeding dan sebagainya lah. Or monitoring, invasive monitoring dan sebagainya. So, this is because the sepsis guideline ni maksudnya develop untuk negara maju. Tapi bukanlah kita kata benda ni tak boleh apply langsung kat negara kita. Kita kena sesuaikanlah dengan kita lah. So, bila kita buat quick SOFA, maksudnya patient yang quick SOFA score 2, these are the sort of patient that you need to pay attention to lah. Kena selalu buat review, kena selalu assess. And targets tu kena ada lah. Okay. Fluid resuscitation, 30 mils per kg ni berapa banyak? Biasa bagi fluid berapa banyak korang? 1 pint normal saline run fast. 1 pint normal saline over 1 hour. 30 mils per kg ni, kalau the person is 70 kg, 2.1 liter kan? About 4 pints.
4 pints.
So korang bagi 1 pint over 1 hour, lepas tu tinggal patient. So most of the time, kita punya fluid resuscitation is inadequate. And sometimes, satu lagi perasan tak? Dia punya fluid 30 mils per kg ni, dia tak ada cakap be careful in patient with heart failure or patient in fluid overload dan sebagainya. Perasan tak kenapa? Sebab for them, bagi je fluid. Kalau SOB, intubate. Kita berkira-kira sikit nak intubate sebab kita mengenangkan ICU tak ada katil dan sebagainya. These people, bagi 30 ml per kg in 3 hours, within 3 hours to ensure that patient ni sebenarnya tak hypovolemia. Sebab patient kadang-kadang, patient sepsis, selain daripada sepsis shock, dia boleh ada hypovolemic shock sebab dia tak makan, dia tak minum, kan, dan sebagainya. So, 30 ml per kg ni is to replace the hypovolemic. So, bila awak dah bagi 30 ml per kg, confirm dah lah patient insyaAllah tak hypovolemia. Dan whatever BP low tu adalah disebabkan oleh the peripheral
Sepsis.
vasodilatation dengan vascular leakage sebab sepsis lah. Okay. So that's why you need to understand that kenapa guideline recommendation ni kita buat lain sikit daripada guidelines, because kita kena sesuaikan dengan tempat kita.
Okay, doktor.
Okay, ada soalan kawan-kawan? Oh, dari tadi 9, sekarang tinggal 7. Suruhlah kawan-kawan masuk, pelik lah. Korang ada 30 lebih orang ni. Semua mana pergi semua orang?
Sekejap, okey doktor.
Okay. Okay, habis dah.
Sekejap Aisyah.
Ada soalan ke? Saya dah habis lah soalan saya. Fiza okey Fiza? Fiza dah tak ada.
Doktor tak ada.
Tak, Fiza ada. Saya tak perasan. Okay.
Okay doktor, Aisyah. Sekejap.
Okay.